friends, welcome back to my video in my channel. And today's short video is part 1 of the main topic as ICU acquired weakness. And I'm sure as an intensivist we come across this very important clinical entity, and I will try to embark upon the why exactly it happens, what is the pathophysiology, what is the etiopathogenesis, how can we diagnose it, and of course, how will you treat it. So, and again, as usual, I will divide it into different parts of the various short videos. So, let's start and look at this very important point as to why it happened in ICU. And as we know that of course in ICU you will have the diverse diseases, and ICU is characterized by uh, you have diverse diseases. Of course you can have so many drugs and drugs to drugs interactions, and of course the protracted immobility. So these are the three predominant kind of reasons why it can happen in ICU. So earlier reports, when Osler actually put forward this theory of neuromuscular dysfunction, especially in sepsis, and later on he actually postulated that the peripheral nerves could have problems because of protracted coma. Eventually, it was kind of realized that there could be a myopathy in status asthmaticus, especially with a high doses of steroids, that is hydrocortisone, and with neuromuscular blockade. And then there is something called as CIPN, that is chronic inflammatory polyneuropathy, which is a primary axonal degeneration without demyelination, which was put forward by Bolton and colleagues. And so these are quite the earlier reports as such. And overall, if you see incidence of ICU acquired weakness, you have papers from ARJCCM, Critical Care Medicine, and JAMA. And you could see that they can range from about 25% to about 65% within say about 7 days, which is the average duration. As you could see, the lowest is 25 and highest is about 65%. And as far as definition is concerned, the ICU acquired weakness is clinically detected weakness in critical ill patients in whom there is no plausible etiology other than the critical illness. And we already discussed about the Osler putting forward this theory as rapid loss of flesh. And as critical care becomes more and more advanced, more cases of neuropathy and myopathy were being recognized. So the important thing is that the first thing is it happens, and then the next important thing is how do you recognize it. And you would find a lot of confusing classifications in various literature, starting from critical illness polyneuropathy, that is CIP, critical illness myopathy, that is CIM, CINM or CIPNM, that is critical illness neuromyopathy, and critical illness neuromuscular abnormalities, and of course ICU acquired paresis. So there are various authors and various papers where the nomenclature exists. So as far as the recent definition of critical illness polyneuropathy or CIP refers to patients with ICU acquired weakness who have electrophysiological evidence of axonal polyneuropathy. So this is important. Whereas CIM, that is myopathy, indicates when the patient with ICU acquired weakness have electrophysiologically or histologically defined myopathy. whereas CINM is reserved for the patients who have electrophysiological and or histologic findings of coexisting CIP and CIM. So this could be like a combination of polyneuropathy as well as myopathy. I think this is pretty much clear. And what does various factors which have a bearing on a patient who is critically ill. So you have skin breakdowns, nutritional deficiency because of prolonged immobilization when the patient is sick in ICU, profound weakness which can lead to myopathy and neuropathy, alterations of body compositions, loss in lean body mass, increase in the adiposity and anasarca. There are few neuroendocrine changes. There is also increased vulnerability to infection, and that is the cornerstone of any problem in ICU for that matter, and the brain dysfunction in the form of coma and delirium. So as I was talking to you about the pathophysiology, and it is mainly the endothelial dysfunction. As you could see, there is impaired sensitivity of vasoconstrictive or vasodilating substances. There is the impaired RBC deformability. There is also rolling and adhesion of RBCs, and there is altered glycocalyx, which will lead to all sorts of problems. So there is a flow of oxygen which is altered. So there is impaired backward communication, and it will lead to tissue hypoxia as well. The hyperglycemia is by itself as a kind of isolated risk factor for the same. And of course, as you could see, that these kind of channels which are inactivated and they are closed, and this can also have one of the contributing factors, along with the sepsis continuum. Like you will have the multi-system problems related to all the other systems, including the CNS and CVS and the endocrine. So predominantly these are the four types of causes which can lead to ICU acquired weakness. And as you could see in this particular cartoon, which is from New England Journal of Medicine, it clearly depicts the problem with the mitochondrial injury, the axonal degeneration. There is a nerve ischemia due to the microvascular injury. Again, this is all can be because of sepsis, and of course the sodium channel dysfunction. And this particular table, as you could see, the clinical risk factors and pathophysiological features of critical illness polyneuropathy and critical illness myopathy. So you have various factors like a female sex, sepsis as we discussed, the catabolic state, the multi-organ system failures, SIRS, longer duration of mechanical ventilation, immobility, hyperglycemia, steroids, neuromuscular blocking agents, and all sorts of pathophysiological processes which will ultimately give rise to critical illness polyneuropathy and myopathy. So all these things which we just now discussed in the form of sodium channelopathy, the mitochondrial dysfunctions, and so on and so forth. So identification and assessment of the weakness forms the mainstay of first the recognition. So there should be focus on the four elements. We need to determine the severity of weakness. There could be a characteristic involvement of the bulbar muscles, and of course you could see that whether the patients are aspirating. There could be involvement of respiratory muscles, and you need to actually determine the cause, which can be targeted, where the treatment which can be targeted for the same. So as we know that it actually can initially start with the lower limbs, and then you can have the shoulder girdle weakness or the scapular muscles, and the subscapular muscles which can get wasted. Then you have a pelvic girdle muscle weakness, and then eventually you could have respiratory muscle including the diaphragm, and this is probably the sequence as you could see happening in the ICU. So, as far as the respiratory muscle involvement is concerned, there are three main muscle groups, including the diaphragms, the intercostal muscles, and the accessory muscles. So, any patient with a use of accessory muscles and nasal flaring represents a high work of breathing or air hunger, where the ventilation is inadequate, and clinically, this patient would be kind of pointing towards the weakened musculature. There could be a ventilatory failure or hypoventilation giving rise to high PCO2 or respiratory acidosis, which can also point towards you know the cause of respiratory muscle fatigue. And this is what we are talking about. One is the diaphragm, of course, the intercostals, and of course the accessory muscles. So the respiratory muscle involvement, which is very common, and the information which is gained from clinical assessment is essential, but it can further be corroborated by the use of spirometry, especially looking at the maximal inspiratory force, the maximal expiratory force, and of course the forced vital capacity, FEV1 and PEFR, which offers a composite indices of expiratory muscle force and airway resistances. And of course, when the forced vital capacity is less than 1 liter, or there is a decline of more than 50% from the baseline, and the minimum inspirative force, which is less than -20, which should lead to urgent consideration of mechanical ventilatory force support in the patients of JBS. And as we know, there's a lot of discussion at present point of time, which there are so many cases which are going on in Pune. So the respiratory involvement in the intubated patient may be assessed by the frequency by tidal volume ratio, or which is also called as RSBI, or rapid shallow breathing index, which has been used to predict the successful extubation, although which has a poor sensitivity and specificity at this point in time. The diaphragmatic strength, which can be evaluated objectively using the phrenic nerve stimulation, and of course the MIP, the MEP, and FVC, which can be measured in cooperative patients. So as far as the respiratory muscle involvement is concerned, we talk about something called as MRC, the sum score, and which actually takes into account the assessment of muscle power from the three movements of each limb, the maximal power graded according to MRC scale, and the total score of about 60. So in patients who develop muscle weakness in ICU, peripheral muscle weakness is paralleled by respiratory muscle weakness. The ICU acquired weakness is diagnosed by using the MRC, that is the Medical Research Council sum score, the arbitrary score of 48, which is used as the diagnostic cutoff, and the clinical utility of MRCSS is limited in ICU. Over 30 to 40% of patients are unable to reliably perform the required tests at awakening. So there are these concerns regarding the inter-rater reliability issue. As far as bulbar involvement is concerned, clinically you would find a change in voice, or there is a kind of abnormal phonation, difficulty in swallowing, coughing while eating or drinking, nasal regurgitation, palatal deviation, tongue deviation, and tongue fasciculation. So these are few of the classical parameters which you look for bulbar involvement when you take a round in ICU. So as far as this particular part of ICU acquired weakness is concerned, I think I'll stop here, and I'll meet you in the part 2 video for the same subject in the next video. So till then, take care of yourselves. Bye bye.